So good evening, all of you. On behalf of Translumina, I welcome all of you on this session of DEB Talks, and it's wonderful to have all the esteemed faculty here who will take us to the journey of DCB and with very interesting case presentations on DCB. And before we begin, just a quick look at what Translumina is and how are we exploring limitless possibilities. So if I give a brief introduction about Translumina, it was incorporated in 2000, presence in more than 50 plus countries. We have been 3 times certified Great Place to Work. We have 5 manufacturing units with R&D excellence collaboration with German Heart Center, and 8 strategic partnerships which brings in best of devices like IVL, OPN, Asahi. And we are the only company which has 2 DES technologies, which 10 years of data of safety and efficacy, and all our products are CE marked. Recently, Translumina has acquired Blue Medical, and I am happy to share that Blue Medical is into balloon manufacturing from last 20 years, and they have been manufacturing drug-coated balloons, which is already present in more than 35 countries across the world by the brand name of Protégé. So, giving a brief of Protégé, what Protégé is. So, Protégé as a product has presence in more than 35 plus countries. Its R&D teams and the manufacturing unit is based out of Netherlands. The products are CE marked and EU MDR certified, and the drug coating process as well as the drug delivery process is patented by Blue Medical and Translumina. If I talk about Protégé as a product, we have unique drug application process and wing seal technology, which makes us different from all the other drug coated balloons available in the market. In our drug coating process, basically we inflate the balloon, create trifolds, and then coat the drug inside the trifolds, which ensures there is minimum drug loss during transition. And if I talk about wing seal technology, we are the only company which does this process of sealing the balloon and further crimping the balloon to prevent the drug loss and make balloon better flexible and tractable. To begin with the session, I would like to welcome Dr. Pramod and Dr. Manoj. Dr. Pramod is head of the department cardiology in Vishoda Hospitals, and he'll be our moderator for this evening. We welcome you, sir. And Dr. Manoj, I think he has not joined. So once he is here, I'll give his introduction again. At the expert panel, we have Dr. Louie Fischer, and Dr. Louie Fischer has has experience of more than 25 years. He is chief intervention cardiologist at MOSC, and he has been greatly involved with aortic valve replacement, imaging, CT, with nuclear cardiology, which is very unique in itself. To begin with the session, I would request Dr. Jyotirmaya Dash to start with the session, and to give a brief introduction about Dr. Jyotirmaya Dash. He is Senior Interventional Cardiologist, MGM Hospital, Chennai. He has rich experience of over 2 decades, and he has been very excellent in utilizing imaging modalities, OCTs, IVUS, FFR, and I think he has great experience with rotablation and IVL. So we welcome you, Dr. Jyotirmaya, and over to you, sir, for your presentation. In the meantime, Dr. Pramod, if you would like to add anything, please let us know, sir.
Yeah, thank you, Priyanka. I think I would like to set the context for this discussion. As you know, DCB has been there a long time, but there was a silent period for quite a number of years. I remember using DCBs, I think 10 years ago, but subsequently there was a silence. Then now there is a resurgence of DCB, and as you know, the technology is very appealing, and the concept now is to leave behind nothing. That is the concept. And as you know, there are several disadvantages and also advantages of a stent. The main disadvantage being caging of the vessel, and the architecture of the vessel is altered by stents, and we have been having multiple stents layered in many patients. And when we have the DCB, I think this kind of multiple stent in stent layering and all this can be avoided. and I think it is an expanding field. Initially, it was approved for instant restenosis, but subsequent studies have shown that it is beneficial in small vessels and also in bifurcations. It can be used, and even in acute coronary syndromes in calcification, also in combination with orbital. There are many applications of DCB, and the main limitation of DCB is carrying the drug to the spot. And when we take the balloon into the coronary artery, the main thing is to prevent the drug loss. And I think Protégé has a unique concept where you have a trifoil and more drug is retained there, and then we can take it to the lesion site. And then when we expand the balloon, I think the drug is consistently delivered into the vessel. So that is a very, very appealing, which only I think this Translumina has. No other balloon has this. All others are semi-compliant balloons. So I think we will be happy to interact with our faculty and learn more about DCB and emerging technologies and DCB usage in several applications with their valuable experience. So I welcome Dr. Dash to go with his presentation.
Good evening, sir. Thank you so much for inviting me to give a presentation on this. So good evening, everyone. Today, I'm honored to be in this panel to have a very beautiful discussion on DCB. As Pramod sir rightly pointed out, DCB came almost we have been using this DCB from the last from 2012-13 onwards, and it just was lying in a hibernation for many years, and now there is a surge in the usage of DCB because we found out that the DCB is it only the ISR which we are dealing with, or there is an upcoming indications also, and what are the baskets of or the horizon of usage? So the question is, will DCB replace DES, or can DCB replace DES? So as we all know, DCB is a game changer for ISR. Now, historically, it has revolutionized the instant restenosis and giving a clinical outcomes. We all know that like in earlier days when there was a stent ISR, we used to dilate it and then we used to place one more stent inside. But nowadays we are not practicing those old concept. We are going with a proper 1:1 ratio. We do an imaging. We find out what is the exact etiology and what is the exact morphology of the plaque, and then we try to, suppose there is a calcium, we debulk it. Suppose there are some fibrotic plaque, we use multiple avenues like a cutting balloon and all, and then we do a DCB. Unless otherwise there is a de novo lesion before the stent or after the stent, generally we don't do stenting nowadays. And if you see the number of clinical evidences which are coming up, it's more of in a complex, challenging cases also. The intervention strategies have been changed. So there is a shifting of paradigm, and the versatility of the applications are beyond ISR. It signals that there is a potential shift in the coronary treatment standards, and with the ongoing research, DCB exhibit a potential and it enhances the patient outcome among the various coronary conditions. So what are the basic advantages of using this DCB? As we all know, this DCB is a target drug delivery. It precisely the antiproliferative drug transfers to the area, and then it minimizes the restenosis risk, and it eliminates the need for a restenting. It mitigates or it significantly lowers the very late stent thrombosis, addressing the key post-stent management concerns. And the third is a very important thing. Nowadays we are seeing a lot of younger generations who who are coming up with their early 20, 25 or 30s, and then they are coming with an MI. And then when we place a lot of metals inside, then it is going to have a longer repercussions in long run. So now we are going into like putting a drug-coated balloon in an ACS situation, where it is like a stent-free intervention, where the less the metal and the less will be the complication, and it enhances the healing process. And of course, the DAPT regime, when we are shortening the DAPT, especially more important in a HBR case, that is the high bleeding risk case, where the risk of bleeding is more, and then we are using the DCB, and the bleeding risk is reduced, and it promotes it enhances the patient safety. So as we all know, the DCB is very important in the small coronary vessels. I mean, when the usage of DCB, as we all know, earlier days, I still remember we used to have even 2 millimeter of stents were available in the smaller vessels. So people used to put, in fact, we have also put in a PDA, PLB lesion, OM lesions and diagonals. Now those concepts are being slowly changing. People are embracing the drug-coated balloons. So now we have 3 trials, which is like Restore small vessel disease, Basket small, and then Picoletto 2. These 3 trials, this Restore small vessel disease, small vessel disease, it demonstrate there is a superior clinical outcome with no device thrombosis, and it significantly there is a reduction in the myocardial infarction and mortality. And in Basket small trial, even though there is the adverse MACE is as like equivalent to the deaths, but the most important thing is the fewer bleeding complications. So especially in a HBR case where the bleeding risk is more, probably the Basket small, the DCB scores over the DES. And in a Picoletto 2 trial, it is a confirmed superiority over the stents. In a long-term efficacy, it is basically the everolimus stent versus the DCB. And Restore was a paclitaxel with the Jyotirmaya. So basically, when the DCB, it suggests that there was a notably lower rate of abrupt vessel closure and the MACE. So as of now, we were talking about the small vessels, the branch vessels, the ISRs, and all those things. Now, what about the large coronary vessels? How far we have gone? Are we really justified in not putting stents and then going for a DCB? But then yes, it is a new a new indication where it proves the efficacy and safety of the DCB in a larger vessels also. So if you see the lot of like UX et al. Demonstrated that the DCB significantly reduces the late lumen loss, indicating that the durability of the treatment is better. It has a highly impressive safety profile and the effectiveness of the ostial lesion. Now we are seeing that most of the cases when there is a bifurcation lesion, the ostial is involved, and then we are using the DCB, and then we are getting a great result. And when the same patient comes back for a recheck angio or maybe a treadmill stress test after 6 months, like we don't get any adverse complications or any adverse symptoms. So the bifurcation lesion is a very bold approach, but then we are embracing this concept also, where like we sometimes I was having a case recently where where the PDA origin and the PLB origin was involved, and it's a like 2.5, and then I had to instead of putting 2 stents in that bifurcation area, I used 2 drug eluting balloon, and then it gave an extremely beautiful result, not only during that period, but over a period of 6 months. I think that definitely it will give because the patient is completely asymptomatic and patient can do his own routine works. So probably once I come to know, once I do this stress test or maybe a recheck angiogram later, maybe 3 months or 6 months down the line, probably we will come to know how these bifurcation lesions are behaving. So it reduces the late lumen loss. Plus the hybrid treatment strategy is a very good concept where suppose there is a diagonal and a LAD lesion, you can stent it, and the diagonal can be dealt with a drug coated balloon. So, and it enhances the patient outcomes and minimal complications. When we use DCBs, there will be fewer adverse effect, and it enhances the safety and efficacy of patients with a bifurcation lesion. So definitely bifurcation lesion is a very good indication where we can consider, and instead of overlapping the stents and the strut structure, plaque shift, and there is a change in the carina. So definitely when we have a stent and a DCB, definitely the late outcome will be better. What about the long and the diffuse lesion? Yes, long and diffuse lesion also the DCB has a better role. We have seen, we have done the cases, we have got the result. So the DCB only strategy shows there is a comparable MACE rates compared to the DES. It lowers the late lumen loss, and no stent is always a better than a stent in a very distal lesion. Generally we don't use a distal lesion. Suppose there is a lesion in the distal part of the LAD and the proximal part of LAD, generally we stent the proximal part of LAD if it is more than 3 mm or 2.75 mm, and distally if it's a diffuse disease, generally we use a drug coated balloon. And there is one more thing, that if we have done a drug coated balloon and if there is a minimal dissection also, nothing to worry, because unless otherwise there is a TIMI3 flow, there is no there is no vessel closure, there is no need to worry, because automatically it heals up, and when you do a check angiogram after 3 months or 6 months down the line, you will see a beautifully opened artery without any recoil also. And this treatment is actually changing the DCB only approach is actually changing the treatment paradigm. Now, in a case of a diabetes, mainly there will be a higher target lesion failure because of the diffuse nature of the disease. So in that case, definitely DCB overscores the DES, and DCB is surpassing DES in the diabetic patient, which again it is a good concept, and basically a stent-free future. So the most important thing what we are looking at it is the high bleeding risk, HBR category. HBR category, generally when we see that there is a patient which we can't use a long-term DAPT, we don't have to use there is a risk is very high. So in that case, DCB has a very promising action. I will quote one example where a patient was having a very high risk surgery to be undergone, and then patient was also having a high bleeding risk. So what I did was I did a DCB and allowed the patient to go for a surgery. And once the surgery was done, then probably later on we took the patient for a recheck angiogram. We found that the vessel was absolutely open with a very minimal 10 to 20% recoil. So we left the patient, and the patient is without a stent now, and patient is being followed up by me. So it is actually a boon to the patient as well as the risk. It lowers the risk also. So the MACE rates are on at par with the DES. There is a significant reduction in the major bleeding, and the ability of the DCB to lower the bleeding risk redefines the safety standards in high risk population, making them a preferred choice. And it is extremely crucial that we can use this DCB in extremely complex cases also. As Dr. Pratap said, as Dr. Pramod said, beg your pardon. So he also suggested that like suppose a case where we have done a rotablation, say we have done an orbital atherectomy, and we don't want to place a stent there, and there is no dissection, we have shaved off the calcium, still we can do a DCB in that area, and we have got a very good results also. So these are all the expanding and the basket where we are dealing with, and Protégé is a very good balloon in the terms of that it doesn't release all the drug at a time in a single vessel. Like we can use it for multiple 2-3 places also. Suppose it's a long lesion, we can have it. There has a graded release process where it can release the drug, and then still the lowest amount of drug, which is the third time when we are using the drug, still it is enough for the anti-proliferative activity to happen. So in acute coronary syndromes also, this is a very small subset of patients which we have done the cases where like young patients coming with a ACS where we have used the drug coated balloon also, where the MACE rate is less, the lower late lumen loss is less, and there is a reduction of cardiac death and it plays a very pivotal role in the ACS management also. So the comparative studies in large coronary vessels shows that there is a significant lower late lumen loss with a similar or maybe less MACE rates, and safety and effectiveness for the bifurcation and non-bifurcation lesions. The lower TLR rate in a de novo group versus ISR group, where the effective in a de novo lesion, and feasibility for the ostial lesion in the large vessel. As I previously told, the ostial lesions can be managed with a DCB rather than a stent, and we can avoid 2 stent strategies. So again, use of DCB in bifurcation lesion, the study inside says that there is a substantial reduction in the late lumen loss outperforming the traditional angioplasty. There is no numerically lower MACE rate and the TLR rates, and as we know, the hybrid strategy where DES in the main branch and DCB in the secondary branch, the superior, like the late lumen loss superior compared to 2 stent strategy. So DCB use in long and diffuse lesion, again the long-term outcomes are good, the MACE rates are comparable, and there is a comparative efficacy drug. The DCB only strategy demonstrates an efficacy similar to DES in managing long diffuse lesion, and it lowers the late lumen loss significantly. Thank you so much. The future of DCB, well, DCB is not just an alternative, they are revolutionizing the coronary intervention, so better to act now. Thank you so much.
Thank you, Jyotirmaya. I think you have highlighted all the important points about DCB. One question I want to ask you is, in all the trials which you mentioned as the small vessel, the diameter that is taken is 3 millimeters. But when
2.75
to Indian patient, actually millimeter is a common sense that 2.5, small size stent.
Yes, sir.
So, what is your opinion about this? You would still go with a stent in 3 millimeter, or you want?
Sir, if it is a proximal vessel, then definitely. I mean, if it's a proximal LCX or a proximal
LAD, are you still comfortable using only DCB?
Proximal vessel more than 3 millimeter, I am not comfortable, sir. But yes, any vessel which is 2.75 and between 2.75 to 3, suppose a RCA lesion, distal RCA lesion, or like a circumflex which is distal, maybe 2.75, or a 2.5 to 2.75 in the mid distal LAD, definitely I'll go for a drug coated balloon rather than placing a stent.
Okay, so thank you, Dr. Jyotirmaya, for enlightening us with the expansion of DCB beyond ISR, and welcome, Dr. Louie Fischer. We are glad to have you here, sir. And
hi, good evening. Good evening, Pramod boss. Louie here.
Louie, how are you?
Yeah, oh, good. I think I can see that you are driving or what?
Yeah. Actually, I'm in Bhubaneswar.
Oh, okay.
ICC con.
Oh, great. Okay. So it was actually good to have. Rather good to listen to your viewpoints on DCB. I was just wondered. I am all for DCBs, except the last to echo your thoughts on the proximal large vessel. We are still not comfortable. Maybe it is a thought block. Being used to stenting for every other lesion in proximal vessel, so that I think to come out of that frame of mind, to free the vessel of stents, it might take a while, but all of us are comfortable in doing DCBs from mid to distal anywhere in the coronary tree. So I think we will need more evidence. As of now, the data is not exactly reassuring for large vessels, say more than 3. So yes, I think we will wait for more data. But all other points, I completely agree with Dr. Jyoti. So let's hear from the next person. Yeah.
Okay, so moving on, sir, I would like to introduce Dr. Rutvik Trivedi. He is Senior Consultant Interventional Cardiologist at Zydus Hospital, Anand, Baroda. Dr. Rutvik, sir, holds more than 15 years of experience in cardiac sciences, and his expertise is bifurcation, imaging, and pacemaking, CRT implantation, etc. So, great to have you, sir. Please, thank you for sharing your screen, sir. Please carry on.
Yeah, but thank you for the opportunity, and happy to have experts here. Dr. Das has given a very brief introduction of the role of DEB in various scenarios. Now the technologies are available, and then the questions come which technology to be selected, and the technology selection has to be based on the data and merits. So we know that ISR is referred as an Achilles heel for the cardiologist because it causes a significant challenge to a cardiologist as far as the repeat intervention and the MACE parts are concerned. We also know that the events are almost equal with metal, and it is a study from Resolute Spirit, Leaders, and Compare study. And if you look at the data, that 5-year ISR rate is almost 12 to 15%. So it does not reduce with any drug or any material which is used. So free from any agent you use for the stenting part or any material you use. So limus free, everolimus, sirolimus, zotarolimus, whatever you have used, I think that event has not gone down. So the philosophy of no metal or behind nothing or a sandwich layering, that is almost challenged. So for instant restenosis management, the drug eluting balloon came into the picture, and Dr. Das has discussed various indications, various trials where it has been used. It has shown a reasonable result. In last 5 to 10 years, I think we see that there are newer balloons, newer technologies, especially paclitaxel eluting balloons and sirolimus balloons are in the market. And then comes the question, which balloon to be used? Because the concentration of the drugs in various paclitaxel eluting technology is also different. The way we basically use this crystalline paclitaxel and attach to a balloon, that is also important. Sirolimus faces its own significant challenge as far as the coating part is concerned. So whatever data or whatever science we have right now, I think that should be the base for the usage of this balloon in a current scenario. So ISR is basically a continuous disease, and whenever we think of ISR, a continuous process, the selection or the comparison or the marriage should be on the basis of its relative anti-stenotic efficacy. Paclitaxel and sirolimus, the basic difference are paclitaxel is lipophilic, it is irreversibly binding, it has a strong anti-proliferative action, moderate anti-inflammatory action, moderate positive remodeling. So again, a very important point here to consider as far as the paclitaxel eluting balloons are concerned. It has a prolonged tissue retention and a long-term stability in the crystalline form. Whereas we look at the sirolimus part, it has a reversible binding, it is a hydrophilic, mild inflammatory, both are strong anti-proliferative actions, less positive remodeling, we have data on that part also, shorter tissue half-life and unstable outside the media. So again, preparation and coating with sirolimus coated balloon has its own challenges. In vitro studies, it's clearly shown that the inhibitory property, that means the inhibition of or smooth muscle proliferation is better with paclitaxel balloons. So this is basically a various study, and as the indications were expanding, started with usage in ISR, then the long lesions, then the diffuse lesions, then a side branch trials, then a diabetic ACS, high bleeding risk of patients, and then a large vessel de novo lesions. So we have various trials which are available, and if you look at data wise, so paclitaxel was the most commonly used balloon in whichever trial you select. Most of the time it is paclitaxel. Of course, the drug concentrations were varying. It has started from almost 4.5, then to 0.3, and now agent Medtronic as a 2, and Protégé with the 3 mg microgram concentration is the most commonly used concentration with the paclitaxel eluting balloon. Importantly, safety data which came in 2018 by Casanos et al., where they found that usage of drug-eluting balloon, especially in the lower limb revascularization, had shown a more mortality. But now we have a long data. This is one of the study, Deadless study, where they have clearly shown the safety is not concerned. Most of the time, the paclitaxel balloons were used. Paclitaxel was compared with the paclitaxel eluting stand in a BMH restenosis. In everolimus eluting stand comparisons, it has shown a favorable result. Focal and large vessel data is still lacking. These are the trials, and if you look at concentration-wise, almost all have a 3 microgram per mm square concentration. In a subgroup analysis, as far as the safety part is concerned, male, female, diabetic, non-diabetic, stable, ACS, focal, BMS, DMS, first generation, second generation, or reference diameter wise, safety part is not a challenge or issue nowadays. Same way, when the 3 drugs were balloons were compared, one is sirolimus magic touch, 2 paclitaxel eluting balloon, one has a low concentration of 2 and another has a moderate concentration, that is almost 3 to 3.5 microgram per mm square. What has found that the medial smooth muscle cell loss score was higher with the paclitaxel balloon compared with the sirolimus balloon. Same way, the PCB showed significant lesser muscle to artery ratio than a sirolimus eluting balloon. These are 2 comparisons. They are not head-to-head comparisons. So paclitaxel, we have a Paul registry from Netherlands. Sirolimus is a Istanbul registry, and we all are quite aware that in Paul registry, almost in 68% of the cases, the pre-dilatation was not used. So that important message we learned while using a drug-eluting balloon, that the lesion preparation has to be proper before implanting a drug-eluting balloon. So when they were compared, in fact, what we found that paclitaxel was safe. In fact, sirolimus had shown a numerically higher event rate when 2 different trials were compared. And again, important in both the studies, in fact, was that the lesion preparation is very, very important. What we see basically in a drug-eluting balloon, so we see acute gain and see a late lumen loss, and what is a net gain we have at the end of the study period. And importantly, a 4th parameter which has came up right from the various recent study, that the late luminal expansion part. And I think Dr. Das, you have talked about the dissection part. The dissection part safety versus in sirolimus versus paclitaxel, it is found that the paclitaxel plays a vital role as far as the dissection is concerned. Not only it is same, but it later on causes a late lumen expansion. So inhibition of a medial tissue and endothelial inhibition was greater with the paclitaxel. Now coming to a sirolimus eluting balloon, we have very limited study, and whatever data or studies we have, if you look at here and compare, first important part is a late lumen loss. It was 0.31 for a sirolimus balloon versus 0.18 with the paclitaxel balloon. Other studies, they were not almost having that efficacy to compare the 2 technologies. Istanbul study was comparing it with the instant restenosis, plain balloon versus sirolimus balloon, and that also in a diabetic patient failed to show any benefit. Now this is again a new study which has come up in Europe PCR, where it is found that the PCB and sirolimus are almost have the same, but numerically the PCB performs, paclitaxel balloon performs better. Diabetic part, and now the indication is also expanding. A sirolimus coated balloon, when used in a diabetic patient, in fact, the ELRs were found to be very high. In fact, the sirolimus coated balloon and the manufacturing system marketed in a way that long diffuse diabetic patient, it should be an indication. But in fact, in diabetic patient versus non-diabetic patient, it has failed to show any benefit over failed to show a reduction in the TLRs when compared to the non-diabetic patient. Same way, when compared in a small vessel disease, SCB failed to demonstrate non-inferiority. In fact, if we see that the late luminal expansion was 53.7% with the paclitaxel balloon versus almost no late lumen enlargement, which was not at 50% reduction was noted. So small vessels, we are almost craving for the larger lumen size. We had acute gain, and then later part comes what is net gain. So net gain becomes more with the sirolimus eluting, paclitaxel eluting balloon. Same way for de novo lesions, late luminal arrangement was most frequently seen with the paclitaxel eluting balloon. So whatever data we have, there were no head-to-head comparison. In fact, there were few trials, numbers were small, but important part, it is a late luminal loss and late lumen expansion part. Both were in favor of a paclitaxel eluting balloon. Now I will show the one important case, the expanding horizon of the case. I had a 59-year-old male, diabetic hypertension, CKD, stage 2 in 2019. Almost all, he is known case of triple vessel disease, CABG, refused, opted for a medical management, recurrent admissions for heart failure, sepsis, GI bleed in 2022, repeated admission led to usage of HD and ultrafiltration. Later on, in 2023, he had a 4 admission on a maximum tolerable therapy. 2024, he had 2 admission. It creates from increase from 2.5 to almost 4.2. Ejection fraction was almost in a preserved to mid-range part. It was his RCA, almost diffusely disease, but some landing zones were noted. Circ was totally occluded, and LED is small vessel. Diagonal is also small and diffusely diseased. We opted for RCA angioplasty. Minimal contrast angioplasty was used. Mid segment of RCA was found to be heavily calcific. Minimal lumen area was almost 2.7. Calcium was noted. It was captured with the IVL of 4. Once noticed, the proximal to mid part was stented. The distal lesion of RCA to PLV was again imaging, and later on balloon was done. And as Dr. Das was discussing, the proximal stent and distal DEB was used in RCA with a good result. Almost 30 ml dye was used for the RCA, and final expansion was reasonable. We also treated LED. Now you have various sizes which are available, 2.25 by 30. So LED was pre-dilated. DEB was used, 2.25 by 30. Diagonal was also pre-dilated. DEB was used, and we had a good final result. Patient is off dialysis, he is maintaining a create of 4.5, and is planning to enroll himself for the transplantation. So high bleeding risk patients, small vessel diffuse disease, the indications are almost expanding and the data are coming. So I just conclude that regarding paclitaxel, a concern raised by a paper by Casta now in 2019, that is no more concern, because most of the data we have is with the paclitaxel balloon. In fact, a sirolimus balloon have no such kind of data which is available. Same way, the indication wise, of course, European Society has slightly changed the indication of DEB in ISR, because in 2018 it was a class 1 indication for DEB and DEB, but recently they made it a class 1 indication only for the stents, not for the DEB, based on the data. Alternative therapy, as mentioned, sirolimus balloons are available, but the merit and data is in question, and data is emerging, but the world is divided. I think in that scenario, the merits and the parameter should be our guide to choose which DEB should be used in appropriate conditions. Thank you very much for the kind and patience hearing, and happy to have any answers here.
Yeah, Dr. Trivedi, I think you have highlighted nicely about the difference between paclitaxel and sirolimus eluting balloons. I think it's very appealing to understand the pharmacodynamic mechanism of the two drugs. Actually, the paclitaxel is more focal effect, whereas sirolimus, when it is used, it percolates across the coronary tree. But in DCB, actually, you want the effect to occur at a particular spot. So I think that is the crux of the difference between the two. And the case example which I have shown is also really contemporary, because now we are also using in proximal lesions a regulating stent, and then in the distal DCB, and with durable results.
Yeah.
So, any other comments are there from the other panel members? They are
Yes, so Dr. Trivedi, just one question. So is it your habit? Because these days, added on to the already established benefits of imaging, these days the stress is on achieving adequate lumen area before going ahead with DCBs or wherever it is. So do you have this habit of imaging in every other case of DCB, or it is your gut feeling to go ahead depending upon the visibility on the angiogram?
Sir, I think that depends upon the indication for which we are using a drug-eluting balloon. Large vessels, as most of the time, instant restenosis is the most frequent encounter in my practice. So large vessel instant restenosis is the most common indication. But a small vessel diffuse disease, where you also feel that the negotiation is going to be a challenge, I think in that scenario, angiographic estimations and then selection of a drug-eluting balloon is the mode we generally go. Because
yes, but the issue is, if you have say on the angiogram, it is a true, say, 2-ish type of vessel, 2.5, and you feel that the lesion has not really yielded well. Say there is about 40% waste remaining, and there will be always an ambivalence whether to dilate with a higher pressure balloon or with some other device. But it is like a catch-22. If you end up in a flap, a flow-limiting flap, then you are in a fix. So those type of scenarios.
Yes, so I understand your point. What you mean to say, the results are not as per the indication wise. So 30% is a conventional cutoff which has been mentioned, that if you do ballooning and the result or a residual stenosis is around 30% and more, in that we are in a soup. And in that scenario, going ahead with the high pressure and then apply a DEB in that scenario, or you imaging, find out the cause why it is not expanding, and then go ahead with the high pressure. And in that scenario, if the dissection occur, you put a stent. That is what the dilemma which we generally face. So in my practice, I would say that in that scenario, again, because the finance becomes an important challenge here, the drug-eluting stents are much cheaper, drug-eluting balloons are slightly costlier, you add an imaging part, so that becomes a crucial part. But of course, if the results we are not able to achieve in a large vessel, especially the instant part or a side branch or a diabetic patient or an ACS patients where you have used it with a specific indication to avoid or to give a metal layer to a patient, there of course imaging should be used ideally, and then appropriate strategy. The lesion is not yielding, still you are leaving up, or 30% and more is unacceptable as far as a drug-eluting balloon strategy has been selected as a primary modality, because that will lead to more complication. And that is what initial study, or the study from the Netherlands also showed, that if you fail to do pre-dilatation, because in 67% of the patient they fail to basically prepare a lesion. So good lesion preparation is vital. In that scenario, I think using more modalities like a cutting balloon, or you have scored balloons which are available, that should be used. At least you should have a residual stenosis of less than 30%. Then I think a drug-eluting balloon should be used.
Thank you.
So, thank you, Dr. Rutvik. Good evening, Dr. Manoj. We are happy to have you, sir. And thank you for joining in. And Dr. Manoj does not need any introduction. We all know him very well. So, Dr. Manoj, currently, for the benefit of the group, I am introducing him once again. He is a senior intervention cardiologist at Kaveri Hospital, Chennai, with an illustrious career of 28 years. He has expertise in every field and is dedicated to patient to a great extent. So thank you, sir, for joining us. And
welcome.
So sir,
I think I was really engaging and listening to the exciting discussions. Louie Fischer was raising a point about suboptimal lesion preparations with 40% residual stenosis. Would you consider for a DEB? And then and also the discussion and response by Dr. Rutvik was fantastic, because he did say that these are the situations where we need to do the imaging and understand how best we can modify the plaque much more. And there are many umpteen number of tools that we have in current practice to modify the tools, and then still DCB could still remain an option once we have modified the plaque to the optimal extent. As far as there are no flow limiting flaps, and the studies also show that if you can measure an FFR, but I would say that measuring an FFR in such a lesion, and we know that the current generation of the pressure wires are not so flexible, and they're not so vessel friendly to advance through it, and it might itself cause more injury and cause more dissection. So we certainly know that these are small vessels, the distal vessels, and or mid segments or side branches, and still we think that we have a very, very optimal lesion preparation. We can certainly go ahead without even measuring an FFR.
Thank you so much, sir, for adding on your points. I would like to invite the next speaker, Dr. Ajay Pratap from SCPM Hospital, Gonda. And we welcome you, sir. Over to you, sir, for your presentation.
Thank you. Is my screen visible?
Yes, sir.
Yes, of course.
Thank you. Thank you for the confirmation. A very good evening to all the respected panelists, and my warm welcome to all the delegates and the people who are watching. I'm Dr. Ajay. I'm going to talk about the role of DCB in small vessels. This has already been discussed in this panel discussion that DCB facilitates faster homogeneous transfer of evaluated drugs and avoid multiple layers of metallic states. I will be limiting my talk on with respect to small vessel disease only. So coming to the data, first of all, we have to understand what it says. Since 2010, there have been number of trials. The mentioning of the trials of the Piccolo Pro trial, which the 5-year data Piccolo Pro 2 trial is also available, where we have compared this with DCB as a zero host small vessel diseases. And in all these trials, including the Bello trial of 2012, the target lesion failure and all this was statistically non-significant when compared to DES versus DEB in small vessel. Whereas small vessel criteria was criteria to be 2.75 and 2.8 in respective trials. Similarly, basket trial of 2018 restores small vessel disease and Piccolo Pro 2 trial in most recent 2020. All these trials have shown non-infective or similar better effect of DCB index that has brought us. Now, this is a very important chart where we have to understand the use of DCB in small bony vessel. These are the most recent 5-year data where the restores small vessel disease have shown optimistic results. Similar rate of deaths and MIS was seen in patients with 5-year data follow-up basket small bone trial. In Piccolo 2 trial also, DCB has shown similar MIS effect, and there was significant reduction in abrupt vessel closure when compared to DES in the DCB arm. And in the analysis by Megail and they have shown lower level loss in DCB, lower risk of MI, similar MIS, death, target lesion revascularization. And similarly, another meta-analysis of 5 randomized control trial published in 2021 has shown similar risk of target revascularization. So this has brought to the point that where we have very comfortable using DCBs in small vessels. But the most important point on these things, lesion preparation, to achieve optimums, there should be a careful lesion preparation. It is recommended to use semi-compliant, non-compliant with 1:1 ratio. DCB are used in current guidelines. It has shown the optimal lesion preparation reduces event rates after DCB in patients with ISR and even in small vessel disease de novo lesions. Now, another point that I like to handle is about DCB handling, that after lesion preparation before DCB point should be considered maximum inflammation of balloon with correct size of further residual stenosis after the application of DCB should be less than 30%, as discussed by Dr. Rutvik previously and highlighted by Dr. Singh also. And there should be no any dissection more than type C or limiting after the use of DCB. When coming to handling of DCB, it should take in care that we should not directly touch or allow the substance on the type CB to get wet because it can release the drug prematurely. In this context, I'll mention that the recent most used introduced DCB by the Blue Medicals, which is marketed by Translumina, that is a Protégé balloon. It has significantly decreased effect as there is great release of drug, and it helps out in covering lesions in very long lesions also, where we can use a single balloon basis. In addition should be played to specific instruction of respective balloon branch, and DCB should cover prepared lesion at least 2 mm approximately and distally to avoid geographical mismatch. Now I will be showing some cases where I have used DCB in small vessels, and these are the cases with acute syndrome. These are the patients where we have to judge and do the cases in a very nick of time. So this is my 56-year-old female presented to us with acute onset chest pain of 2 hours of duration. ECG was suggested of lateral wall MI. Echo showed abdomen lateral segments and ejection at 45. The patient was diabetic, frail, with history of bleeding from rectal attributed to untreated underpressure. And after consent, the patient was taken in angiogram. And because considering the clinical scenario of this patient, I was already making my mind that I will be using DCB with the following effect of use of short DAPT in such patients. So this is the diagram of my patient with RC normal. You can see the circumflex and the visual volume which was normal. However, there was 100% occlusion of distal terminal OM. Here we can see, and considering on the angiographic view, we can assess that this vessel is not that big. It looks like a small vessel. So what I did, I dilated the lesion, as I've already mentioned. For success of DCB in any of the vessels, be it de novo or ISR, lesion preparation is the key. Here we have dilated the lesion with a cutting balloon of 2.5 to 10, following which a DCB was implanted of 2.5 millimeters and 30 millimeter. And to my surprise, the trackability of the balloon was exceptional, because this guide is of 5 inch because of being lean and thin and short-heighted female, and radial artery is passed by a 5 inch guide. And despite that being angulated, the level of the balloon was exceptional. And after inflation of the DCB for 90 seconds, which I usually do, we have a conflict here. I use mechanical properties of the balloon, and I give inflation in 2 parts, where I give 90 seconds initially, then I wait for 10 seconds, and I wait it again for 90 seconds. As for DCB inflation, however, it is very clear in all the data, paclitaxel release is done in the first 30 seconds only. So this is my final result. There was flow limiting region, there was TB3 flow, and we can clearly see the vessel was of 2.5 millimeter, and I have saved the patient from any following stent studs. Similarly, what is the role of DCB in side branch? This is another patient which came presented to me with acute lateral wall MI. Patient was in cardiogenic shock, window period of 3 years, and I had to make a decision in a nick of time what has to be done. The patient angiogram showed a left dominant system, ectatic LCA with a total near occlusive lesion of OM branch. That was Optimus, which was of also a large size. Considering the mismatch and the hemodynamic presentation and hybrid approach of DES and DEB was planned on me, because there was significant plaque in LCX, and LCX was of very large size, and I cannot afford to lose major OM. That was also a big branch, and it is visible there was significant calcified eruptic calcium nodule at the ostium of the OM, which was most probably the cause of coronary syndrome. So in this patient, we dilated both the vessels. I have used a cutting balloon for the side branch also, and vein vessel also. After stenting the main vessel with a 4x24 stent, I have done a kiss. In this kissing has to be noted that I have done the kissing with a DEB straightforward, that is a DCB of 3.515. And after doing kissing, you can see I have saved time. I have saved the steps of bifurcation rather than making it troublesome for me. And this is my second week where I was describing that in this patient there is high risk cardiogenic shock patient with a complex anatomy, anatomy, where I cannot deal with losing branch also, and I cannot leave the main vessel. Sorry for interruption. This is a case where I have already shown that OM was significantly diseased. There was calcium nodule at the ostium of the OM. So what I did, I kept close as the patient was included cardiac heart failure, acute MI. So I take vessel because I cannot use the left dominant major vessel. Okay. So this was my final result. I have achieved luminal gain complex and dissection kind of limiting dissection. The OM was also saved, and the cycling was also saved. My patient was well. They freed the patient from additional pain and there was some stenting also, and we all know that doing modification, DE crush or mini crush, we all have a lot of ISR, and because the change of the carina and dynamics changes, and in such cases they were hit.
Yeah, it's okay, Ajay. I think it was a nice presentation. The technical issues would always be there. And we saw some of your cases where the application of DEB was illustrated, especially the distal diffuse small vessel OM and also the side branch and bifurcation. But I'm not sure whether in an acute MI settings, whether we'll have much role of the DEB, particularly because there's a lot of inflammatory markers, and how the inflammatory markers and the healing in the vessel could interact with the low dose or intermediate dose of the drug which is available on the drug-coated balloon. So that's only, it's a growing experience. There are no specific recommendations for use of DEB in acute MI, especially in STEMI settings.
Yeah, I 100% agree with you, Dr. Manoj sir. But what I, at the time when I have to consider that the patient is having cardiogenic shock, and I have to save the side branch also. So I have used in hybrid these procedures because I was not sure that will my patient be able to consider his hemodynamic condition, he will be able to bear the procedure, and I will be able to bifurcation, whichever technique I would have used, it would have taken time, and as we all know that circumflex is often very tortuous and significant problem. In this case also I dealt with significant problem, so I recently have started this technique of hybrid test, and we have seen many number of patients, many number of reports regarding this on where we can simplify and we have acceptable results. I did imaging in the previous case also, in which I have used it in primary PCI for OM, and there was a wonderful result. There was very minimal recoil, and I am routinely using it in small vessels induced ACS, like in small ramus OM diagonals. It is better to leave those vessels with DC rather than giving it as a stent, because it is going to prove problem in the future of ISR, because often these lesions are ostial or have their component in the main vessel also. So rather than touching the main vessel, it is better to do a DCB and get out from that place in acute settings. And similarly for this for the elective patients also, if we consider that small vessels are there, we can always go for DCB rather than giving a stent, because that's my last slide is forever. It's like a human, we should leave nothing behind, which what we are trying to do in stents also. We are doing magnesium scaffold, we are doing the same thing. So if we can just remove the scaffolds and studs, and then it would be a very great help for the patient.
Hi Ajay, I thoroughly enjoyed your presentation. Those cases were nice, but regarding the DCB preparation, I beg to differ. You can actually liberally wet your DCB before you thread it onto the wire, because most of the DCBs, especially the Protégé, actually the drug elutes out when the balloon is expanded. That is how the threefold usage of this balloon is possible. You deflate the balloon. Once the balloon collapses, there is no more elution. You pull out the balloon, and you can use it in the second geographical site. So that is not a problem. I think Dr. Saxena can illuminate us more regarding this. Otherwise, I agree completely with all your points. Even I use DCBs in some of the horrendous vessel where you can't use a stent in STEMI setting. So we are quite comfortable with DCB usage in STEMI. But Dr. Manoj's concerns are valid. But for the time being, we are okay with DCBs in STEMI if indicated.
Yeah, I agree to that, because I've also used in STEMI settings. But we just have to be understanding that we are just evolving that practice. We may have to understand closely whether these patients are benefiting really, and follow-up angiography and see whether these patients also equally benefit in the STEMI setting also. So other or chronic coronary syndrome patients are distinctly is a choice, an acute MI or STEMI. Definitely, I think this gives a scope for us to follow up and understand the role in a better way.
Absolutely.
I'll absolutely agree with Dr. Fischer, who has mentioned that specifically with Protégé, that the balloon, that all that trifold design that has been introduced by these people. However, I have mentioned that statement for all the companies, because we have to understand it is not only a single balloon that we have in our shed. We have number of balloons, and all the balloons have different design. So handling a balloon, if we make a dictum rather than using only one thing, this is a very beautiful thing that has been introduced by Blue Medicals and that has been marketed by Translumina. And the beauty of this balloon is that we can use it twice. This is the most important thing, because often we land up into small vessels or diffuse disease where even 30 millimeter balloons are short. They fell short. And considering the economic constraints and the cost of these balloons, so I think this is very cost effective for the patient also, that we can do it in 50% bias in very long lesions also, if it is more than 30-45 millimeters and up till 60 millimeters. Thank you for that issue.
Thank you, sir. Sir, as very nicely elucidated by you, sir, as the evening proceeds, we will go to our moderator and speaker, Dr. Manoj sir. Sir, it was Dr. Debopriyo sir. Actually, Manoj sir was slated to be the first one, but because of some engagement, capital engagement, he was late. So, if you don't mind, sir, who would be taking up this, sir? Sir, so, sir, kindly request Manoj sir to go ahead and please kindly go ahead and speak about this evening, sir, about his experience. Thank you very much, sir, and thank you, Debopriyo sir, for adjusting it, sir.
Yeah, thank you for the opportunity, and I regret that I couldn't join in the beginning because of my commitments to the hospital, and regret that I'm giving an introductory talk towards the end of the session. So I would be quite brief about the concepts. We certainly know the evolution of the balloon angioplasty from the days it was introduced by Professor Andreas Grensick in the Emory University in Atlanta, and it moved on to introduce the bimetal stents for the acute luminal gain and also reduce the procedural success, as well as reducing the recoil. Subsequently, we understood that there was a need for drug-eluting stent, as at least 30 to 40% of patients with bare metal stent implantation, with those kind of practices at the time, with not so high pressure implantation, which later came as a dictum of PCI for more optimization in the imageless era, with Antonio Colombo propagating the high pressure stent deployment. The need for drug-eluting stent was an extreme necessity at the time, and came as a significant boon in the early 2000s with the introduction of the Cypher stent and also the Palma-Scherz drug-coated stents. So these were evolutions that we understand, and subsequently we've been extremely comfortable with many generations of drug-eluting stent implantations. Having said that, we also know that the limitations of the drug-eluting stents, making the vessel causing a long-term injury in the form of neoatherosclerosis, and also causing a very late as well as a late stent thrombotic ischemic events. So there is certainly, definitely, if you leave a metal stent inside, especially when we see our population of patients in the younger generations, and I'm sure all of you agree that in our practice, it's not uncommon to see a patient less than 40 years of age with a coronary artery disease, and especially an extensive coronary artery disease in our population or the Asian Indians. So therefore, we need to be very considerate to understand whether they really need a stent, whether they can be managed without a stent, and whether we can also consider in some of these instances a bioresorbable scaffold, especially because we know that atherosclerosis is a progressive disease and not a one-time issue, and the events continue to occur in any patients who have an established cardiovascular disease. So therefore, the concept of not leaving anything behind with the introduction of the bioresorbable scaffold, and later with the newer concept or the fourth revolution, what is called as a drug-eluting balloon or a drug-coated balloon. The essence was to release the drug into the vessel wall and that moderate the healing and also have a controlled healing response with late luminal gain, as well as we see in many of the diffuse disease, especially with the diabetic population being significantly occupying the majority of patients that we come across in our practice. So it is similar to what is called a polymer-free stent, because in many of these cases of drug-coated balloon, there are no polymer, and there's only nanotechnologies or other forms of technologies or carriers or excipients that would be used as biological excipients that are used to deliver the stents, the drug into the vessel wall. So both are synonymous. Drug-coated balloon as well as a drug-eluting balloon are synonymous, and the drugs could vary in various forms. It can be either limas family or the paclitaxel component. So one, it has an anti-proliferative drug, and secondly, the technologies have evolved to conserve the dose availability to the target lesion site by reducing the transit loss as well as the loss in the circulation as well, while we deliver it from the system into the vessel wall, and reducing the particulate embolization, and also have a better transfer efficiency into the tissues by having, as I said, excipients in the form of a urea or many other biological agents. And the coating techniques also varies from the type of the drug-eluting balloon. We certainly know that the dose also is variable in various types of balloon. Even among the sirolimus coated drug-coated balloons availability, the drug varies. Among the paclitaxel coated balloon also the drug varies, and therefore it has its implications, and there's not been any head-to-head comparison of the various agents available. Now, this is a very well-known fact that the paclitaxel is more retained in these tissues, and therefore it's very fast absorbing. It has got a cytotoxic as well as a cytostatic effect, and therefore has a much better healing process of regulation, and causes apoptosis, and contributes to more greater positive remodeling with a late luminal gain, as we see in many of the applications of the small vessel diffuse disease where we apply the drug-coated balloon. The late vessel remodeling is a significant factor which is seen in a superior way with the paclitaxel coated as compared to the sirolimus coated. And this is distinctly seen as in this graph that the minimal luminal diameter post-treatment is much larger as compared to the minimal luminal diameter achieved with the sirolimus coated drug-coated balloons. So we have to necessarily have an optimal lesion preparations, which is a fundamental before considering the application of drug-coated balloon or a drug-eluting balloon. The standard semi-compliant balloon is often used, perhaps an undersized balloon initially, and then you can use a non-compliant or a scoring balloon or a cutting balloon, depending on the type of the plaque morphology that would require such newer devices or special devices for 1:1 ratio to prepare the balloon, to prepare the vessel site or the target vessel site in an optimal manner without causing a significant flow limiting dissections. Often these drug-coated balloons can be used in combination with the newer technologies of rotational atherectomy, orbital atherectomy, and also lithotripsy. Intravascular imaging distinctly adds much value as much as in the stent implantation, and optimal PCI outcome remains the same in either whether you implant a stent as well as whether you apply a drug-coated balloon. So once you achieve, after all the preparations, optimal angiographic criteria with the no flow limiting dissections, residual stenosis of less than 30%, and FFR of more than 0.80, these are the type of patients or lesion subsets that can be considered. If not, they are in proximal location in the mid to distal or in the last course of the vessel. So if these criteria are met, certainly one can use a drug-coated balloon and the drug-coated balloon should be delivered the time possible to prevent or to reduce the loss of the drug delivery during the transit. And inflation time is generally around 40 to 60 seconds. But I certainly sometimes keep it for a longer period of time because we know that there is some loss of drug on the transit, and I might leave it even if the patient can tolerate for about 90 seconds so that whatever maximal drug can be delivered into the patient, it's a vessel wall, it can be certainly be provided. The patient has no hemodynamic stability. So pre-dilatation of the lesion, as I said, with the 0.5 smaller balloon that is intended diameter, and then use a 1:1 non-compliant balloon or even special devices to prepare the lesion well. Minimize the transfer time from the access to the DCB inflations at the target vessel side or segment. Single prolonged inflation is better than for a complete drug transfer, up to 60 to 90 seconds. Sometimes if the patient does not tolerate these balloon occlusions and you have an ST elevation, brady or hypotension, or even sometimes triggering arrhythmias, you may have to fractionally release the balloon and allow the perfusion to be re-established, and then again give an intermittent inflation till the recommended time is completed, and not more than 3 minutes. Of course, the DCB can be retained in the blood vessel by tamponating the flow. So to minimize the drug loss, these are some of the methods that we can utilize in patients who could not tolerate a prolonged inflations of more than 30 to 40 seconds. So all DEBs are not equal. They are different in drugs and the doses, the manufacturing techniques, and the drug release kinetics. The doses and the delivery balloon characteristics differ, and we could always conceive in ourselves that then could be better to understand a head-to-head comparison, which is unlikely to happen perhaps for the reasons that we understand in a better way. So this is an important, as I said earlier, just a gist and wrap up. Acceptable angiographic results with a no flow limiting dissection, residual stenosis less than 30%, FFR of 0.8 or more if after the preparation of the lesion. In case you wish to measure the physiology before deciding about the drug-coated balloon or stent, and you can always ask additional options, consider rotablation, atherectomy, orbital atherectomy, or lithotripsy, and also consider if these are optimal results are available, you can apply the DCB. If the patient has a flow limiting dissection and residual stenosis is more than 30% and FFR is a distinctly significant value of lesser than 0.8, then obviously we don't want the vessel to recoil and close and cause an ischemic event in the patients, and stents or scaffolds will come in a bigger way as a choice in such kind of lesions. Now, this is a meta-analysis of all the pooled studies, which is very important to understand that over a 10-year period, you will see that the upper graph is the plain balloon angioplasty, and they have the highest primary endpoints of myocardial infarction, repeat revascularizations, including the cardiovascular mortality. But if you see the blue line, which is the middle part, it traverses in much the same trajectory, and the curves doesn't divert much as much as the drug-coated stent up to 5 years. So after 5 years, you will see that there is a continued positive remodeling and luminal gain by use of the drug-coated balloon, and it stays at even 10 years. You will see the luminal stenosis or luminal gain is much superior to the drug-eluting balloon, and distinctly making it as a very, very important choice in the kind of practices that we see in our population with the diffuse disease, small vessels, and also diabetics, and also simplifying some of the complex bifurcation techniques. So the unique drug applications in the Protégé distinctly brings it with its advantages of the wing seal technology, where the folded and the inner folds retain the drugs and also reduce the loss of during the delivery of the drug during the transit, and the tight wrapping prevents balloon unfolding, and it can be used for even applying at multiple times in the same vessel segment over a longer segment with long lesions. And therefore, a single balloon could even cover and deliver the drug over a long period of time. So with these things, I would say that let me complete my presentation that some of the indications, if the Klana indication is distinctly the type A or the focal incident restenosis, small vessels, de novo lesions in a select population of lesion size or lesion types, and bifurcation lesions, especially the side branches. So as we also saw some of the presentations, we will also continue to have this hybrid approach with the DCB and DES, or DCB with bioresorbable scaffold in a hybrid manner in many of the lesion subsets like multivessel disease, complex CTO, and high bleeding risk, and young patients, especially who have early onset of diffuse atherosclerosis. Thank you for your attention and listening.
Thank you very much, sir. So over to Dr. Louie Fischer, sir, for your comments and questions along with the team. Sir, you are on mute, sir, Dr. Louie Fischer.
Hello, am I audible?
Yeah.
Yes,
Okay.
of course.
I think there is one more presentation. I think Dr. Manoj has beautifully summed up and has rushed through whatever is the biology and the pharmacology behind this technique. So I think we will listen to the next speaker and then we will have a final discussion. Is that okay?
Yeah, sure.
Thank you.
So, am I audible?
Yes, you are.
Yes, sir. Yes, sir.
Okay, thank you, Translumina, for providing the opportunity. Actually, I do not have much time left. I have a flight to catch from 9:30, so I'll try to finish off in 5 minutes. I'm very sorry for this. My topic is maintaining vasomotion with DCB, the lesson from DES and BVS trials. So, vasomotion is ability of the blood vessels to constrict and dilate, which is crucial for regulating the blood flow. And the importance of vasomotion is because healthy vasomotion indicates good endothelial function, essential for cardiovascular health. Vascular reactivity is maintained vasomotion, allowing the arteries to respond appropriately to physiological stimuli, enhancing the long-term vessel patency and reducing the adverse events. DCB, DES, and BVS, these technologies are employed in the percutaneous coronary interventions to treat coronary artery disease by preventing restenosis. So the lessons which you have learned from the DES trials, the initial success with DES is because of the restenotic rates which were reduced as compared to the bare metal stents and the POBA days by releasing the anti-proliferative drugs like sirolimus, paclitaxel, and so on and so forth. The impact on vasomotion, chronic inhibition, DES can lead to chronic inhibition of endothelial cell proliferation and smooth muscle cell migration, impairing vasomotion. Delayed healing, the long-term presence of polymer and drug can delay endothelial healing, reducing the vessel's ability to constrict and dilate, leading to the clinical outcomes like restenosis reduction. This is mostly because of the delayed effects of the anti-mitotic drugs. Late stent thrombosis, the concerns about late stent thrombosis due to impaired endothelial function and delayed healing still remains, and we have cases of ISR which comes up even with the latest generation stents. Then vasomotor dysfunction, the persistent vasomotor dysfunction observed in many patients are because of the polymer coated things. So the bioabsorber vascular scaffolds designed to provide temporary scaffolding and then resolve, potentially restoring the natural vessel function, including vasomotion. The initial promise of vascular restoration was to restore the natural vessel motion after the scaffold resorption. However, the challenges faced were the early complications related to the device thrombosis, which was seen in the early trials like the absorb trials. Incomplete resorption because of the incomplete and inconsistent scaffold resorption leading to variable outcomes. Mixed vasomotion results, some restoration of vasomotion was observed but not as consistently as hoped. So the advantages of drug-coated balloons came into the form of mechanism of action like these drugs, anti-proliferative drugs, adhere to the vessel wall without leaving a permanent implant. They helped in preserving the vasomotion. Temporary drug delivery directed to the vessel wall, reducing the smooth muscle proliferation without the chronic presence of a stent. There was no permanent scaffold. The absence of a permanent scaffold allows for the natural restoration of vasomotion. endothelial function was likely to be retained. There was less impact on the endothelial function as compared to the DES. In the clinical evidence, as far as we have discussed, we have seen a lot of slides from our learned colleagues and seniors that we have studies which have shown positive outcomes with DCBs in maintaining the vessel patency and functionality. There were reduced restenotic rates and better preservation of the vessel motion as compared to DES. So when we see certain trials, we see that patients with single vessel disease were treated with DCB versus a DES at 8 months. The endothelium dependent and independent vessel motion was maintained with the drug coated balloons vis-a-vis the presence of drug eluting stents. And when we do an argonovin provocation test 6 to 9 months after putting a stent, we always see that the vessel motion reflects it was better with a drug eluting balloon as compared to a drug coated stent. So one of the cases where I used a Protégé 2.515 balloon was a patient of acute coronary syndrome, a young chap who landed in a cath lab at night, and there was a distal LCX lesion which is totally cut off. And after wiring, what I saw was that the distal vessel was around 2.5 millimeters sized. The rest of the vessels were normal. And then subsequently, I pre-dilated the lesion with a 2.20 millimeter balloon. It restored the flow, and since the vessel size was small and it was distal vessel size, I decided to go ahead implanting a drug-coated balloon, although we do not have much of data in the acute setting. However, the downside, or probably I was less fortunate because I had a dissection which was more than grade 0 dissection after implanting deploying the drug eluting balloon, Protégé in this case 2.515, which I had to again cover with a 2.5 stent, and that is what happened in my case. And this was the final result of the patient, wherein I achieved a TIMI-3 flow, but a drug eluting stent had to be implanted because it was a TIMI flow was reduced and we had a dissection. So thank you for your patient hearing, and I'll sign off here. Thank you so much.
Thank you, sir. Over to Manoj sir and Dr. Louie Fischer sir for their valuable remarks, and Jyotirmaya sir, Rutvik sir, all of you are there. Manoj sir and Louie sir, you can kindly anchor the meeting, sir, forward.
I think we have seen good presentations, and people have been practicing drug-coated balloon strategies in many situations, regardless of. So it is an evolving PCI practice. We need to keep practicing in a more safer manner than we otherwise do that once we committed to a drug-coated balloon strategy. If you are committed to a DES strategy, you can certainly go to any high pressures as suitable to open the vessel. But here, the preparation has to be very gentle and gradual. Your intention is not to cause a significant vessel barotrauma and not to leave the vessel with a flap which is causing a significant thrombosis or even a vessel occlusion. So that defeats the whole purpose of using the DCB, and it's a very meticulous way that we have to time intensive rather than finishing in a fast sequence that every one of us has learned to do a type A vessel PCI will finish in about 20-25 minutes. This drug-coated balloon PCI distinctly is a little more time intensive in the cath lab, and you may have to give nitroglycerin, may have to give a diltiazem or even adenosine C, that the vessel spasm is also relieved and there is no distal slow flow, and all these measures, and apply all the lesion preparation criteria and then go forward. So we all certainly know that whether it's a bioresorbable scaffold or a drug-coated balloon, the vasomotion feature is distinctly a natural physiological function of the vessel wall, which gets distinctly disturbed with the application of a metallic platform of scaffolds. So this is a very, very emerging practices. But having said that, I've been this drug-eluting balloon has been available in India for almost close to a decade from an alternative vendor, which we all know. and we've been using that in many instances. The sirolimus coated balloon has been available in India, and we've seen very remarkable results over the period of last 10 years. In the couple of 4 years or so, about close to 4 years or so in my practice, my use of DES come down by 50% with the systematic application of drug-eluting balloon, even up to a vessel of 3.0 in caliber. So, and most of the vendors come and tell me that you have not been using any of our DES, but certainly I think they do get a significant turnover with the DCB. So it's a mutual way of utilizing the technologies available, and as we understand, the practice is not to leave anything behind. The DES would slowly dwindle over a period of time, except perhaps in left main, and also a large vessel bifurcations, and also if there is a significant dissection and flap in the vessel after the preparation. So these are the situations where we probably will continue to have the DES metallic platform, and this is a very, very user patient friendly, especially in the young generation of populations that we come across, who perhaps will need more interventions in future. So the application of DCB keeps all the options open for the patient. The surgeon can even use a graftable if the vessel has a restenosis. He can have a DES or a bioresorber scaphold. You can also have a repeat DCB application in the same site in a much optimal way. So all the options become available, unlike jailing a major side branch with a metallic DES platform. One of the most important understanding is once the DECB is applied, and that's the last step in the vessel PCI. You should not be doing imaging after that. You should not be post-dilating the vessel after that. So once the DCB, that's the last step in the PCI, and that completes the procedure. So these are important considerations. If you attempt to modify the target vessel site with any other modality, it's going to disturb the drug which is delivered there, and the results may not be so optimal. So these are some of my comments that I would like to share.
Thank you, sir. Thank you so much for this. Sum up this. So over to you, Dr. Louie, sir, for your valuable feedback before we sign off this meeting, sir.
Yes, one other scenario, I completely agree with Dr. Manoj's viewpoints, and I think that is the way ahead. Couple of points which I would like to add is, one scenario which is going to be the game changer will be complex bifurcation lesions. So 2 stents, we all of us want to finish off the procedure, any procedure, as early as possible. So 2 stents means it is more complex, and as Dr. Manoj said, it will be time intense. It will be consuming more time. So with a drug-eluting balloon or a DCB in the branch, this procedure is going to be a lot easier. That is one scenario. And another is, previously, even after imaging, so a long segment CTO, we have covered from, we have stented, from mid to early distal LAD, and suddenly we see that the distal vessel is all chewed up, and there is no way to get out. The flow is limited. So if we leave like that, because of the limitation in the outflow, the stents are going to get closed. So such scenario, recently we had a case like that. So after putting a long stent, LAD CTO putting a long stent, we were disappointed to see that the distal vessel is all chewed up. So what we did was a 2.5 Protégé was applied there, and end of the day we had a very nice result. Obviously we had made sure that there was no flap, there is no mechanical issue related to that. So that is another scenario. And also is the fact that long, very, very long segments of the arteries can be covered with DCBs, if not Protégé type or even longer type. So these three scenarios also will be an attractive arena to play with DCBs. Thank you.